hela ne political senele kokra
tole kote mina ke bi no onye oya fo efi o malo ya fo e ya to fo e square la ne le o ke ban shi anem wota o la ne ye shi anem ba o la chamo he ba o fe mo ye jeme nke fe mo ya sure ye jeme sure.
Hello.
Hi.
Oh, madam.
Yes.
Over in Natri.
Natri cry ke la ne keje kra.
Oh.
Ne keje. Ne keje.
Shayo papa. Over in Natri.
Natri cry.
Tashi down.
Dabe na tashi.
Shayo papa mi pa bo fai. Yeta tashi down. Yeta tashi down.
Na change twins.
Oh, you are do. Shayo papa. You're welcome to Ussher Hospital. O fine me di sanye me di sanye.
She mean di ibinu. E ba wo bo ile ka yo papa njibu. Agbenebeni akwa o mo ho. Ho mi wen mo dromo na. O fo hwehwehwe. Agbenebeni akwa ka gbeke ye helako. Ni ela won e ko be wo hia. E won te balete ni gbeke na na hela ne.
O fine me ni hela na ka gbeke yo.
Ke hela. Chegbe han.
Sickle cell hela.
Oh, no che.
Madam. Shayo papa. Kayochi. Natri. Matron bomi. No ni ba. Ke ha ne ke ni neba. Onu nshi. Ewo oba natri magblami. Beni magbena oba na ke asuma sani eje noko choni. Anokwale bi ane Ussher Hospital. Ni modromo na work a sickle cell unit. Watch a ya. Ni won kwe beke bi ne afo ame fresh kashi 9 months won fe won kwa melami ni won na ake ale no sickle cell anemia alo disease ekoya melami lo e won sickle cell anemia disease eji hela ni yo le eye Ghana onimishi agbene eji hela ni yo wo lami ewo before ni yo kenu ban hie e papa mi e sani shuko ame atawo ake ame ye neke hela na ekolo dani ame ba den ake ame ba namusu onimishi ewo hela sickle cell disease aye menkomani wo twa amake ame ye trait eshishinji many of trait ame ye hela eko she hela eje ko ya mehi ewo e ba nye le ba fe no fiano ebe waleda una ka shi beni ekeyo ni yo trait eko ni ji hela afan ba nshi ewo ka amena musu opportunity allo chances ye mi ake 25% chance ye mi ake ame bi e na ame ba for eko ba na hela eko di enche ni ji ss ni menkomenhu ba na career se ni ji as ewo owuyo eba fo ye wo je lele ni wo kwe elam taflache gbeke wona ake hela ekoye ehe shi sane ni yo ngomo ye ene eji bia ne ni kasemo ke wamopi eba ke ha ne kegbeke bi ne ewo bia ne ni wona ake hela ekoye lamie wakale ba fo chufanu mna ona kakale foto fanu mna ibanya ya school pepepe ebe wale basabasa ni mamile ni tumo ba afite ne sane tashi ane kwele alo ekegula afite mo baba ewo akale ba foto fanu no ni nyebanya nye fe nye wa wo page ye ba support mamile koni anytime ni abake eba na doctor eba ba agbene chofaji ni akegbeke eba fono aba kwene ko ke ni elimi ke ni bi ni fitai na ba chonye ye ba ye no na kan hawo ewo hela je ake ni nyemba mi nu ake o ke echon obilese o fine je na kan ni ame enyo hela ya me shi eje ko Ibiane ni amewo ho dani hela eba chiko ye gbeke mi ewo amenyo fe na me contribute na me ha gbeke ina ilane shije no koni gbe ise moyoyi to mo be ni tenkle wie aye gbenoni akeleba atun ni no fiano ba fe fine shai papa ewo energy sani eni yo Oh, finally, I can cry. No one in country, I can. She know no tree, she. No plan, me catch on your Jobani, no she. But no real, and I can know me, my alley. But then let fail a hey, don't. I can tree. Nika time no ba ka wo kekbe kan ba mama milen ni kekbe ke hu ba ba ni no fere na ta na afi ha be ke hu e wo ba ni hu afi ha le ko ni wona to enjole ni ma hu aya no ojuba ora don oyiwa don ake onnumenshi beni nka oba tashi keni bi fe wona twi ingla mi no fia no e wo oyiwa don shikube ko.
So newborn screening started in Ghana here in the 1990s. It was started by Prof. Ohene Frimpong, but they were only screening in Kumasi and then a few places in the Ashanti region. And for more than 20 years, no newborn screening was done outside of the Ashanti region. So it was in 2017 that the Kolebu management, and then led by our hematologist, Dr. Catherine Segbefia, they decided that, you know, this thing has been happening in the Ashanti region for more than 20 years, but nothing has, you know, it hasn't been expanded. They haven't moved to other regions. So they went to seek financial support from Sickle and Pfizer, and the support was given. And in 2017, June 2017, we actually started screening in Kolebu. We had the pilot stage for about 2 years till 2019, and then we decided that, you know, a lot of our cases that we were getting for the positives, they were coming from the communities around Kolebu. You know, we had Chorkor, Jamestown, Bukom, you know. So we decided that, you know, instead of just concentrating on screening the babies at Kolebu, and so what we did was that in Kolebu we only screen those who are brought in, those who come to deliver there. So we decided that we can also go into the community, since a lot of our cases are coming from the communities anyway. So we came here, we spoke with the Ghana Health Service, the Accra Metro Directorate, the director and all of those people, and then they decided that Ussher Hospital was a good place to start. So in November 2020, we actually came here, we trained all of their midwives and then their community health nurses in how to take the blood sample. That's we call the heel prick blood sample process. So we trained them, and then on the 27th of November we officially started screening here in Ussher Hospital. So I think this November, it's 3 years actually since we started screening. Yes, they've screened, I think this year alone, they've screened more than 1,000 babies, and it's been consistent for the past 3 years. They've delivered so much, and I think that the way to go for newborn screening is through the community, screening in the communities. And so mostly the message that we have for, you know, the community, for people, is that newborn screening for now is the way to go in managing sickle cell disease in Ghana. It's once we are able to identify the babies early, latest by 3 months of age, we get them into clinic. We start them with the counseling of the mothers. We get the testing done again, just to the confirmatory test done. The babies are seen by the pediatricians. You know, every 2 months they come in. They are started on penicillin prophylaxis. They are started on the folic acid. You know, so that we can manage them. So that's what newborn screening is about. It's about managing the disease. And a lot of babies die. A lot of children below 5 years of age die from sickle cell disease that we don't know about. And so that's what we are trying to prevent. The mortality, the under 5 mortality, sickle cell disease actually contributes to that. So we are trying to reduce that, and that's why we think that newborn screening in the community is the way to go. So the medicine that we have, it's the folic acid. You know, I mentioned about the folic acid, the vitamin C, and there's also the hydroxyurea, which is the main sickle cell medication that we have. And now on the babies, the children are started, I think, after 2 years before we start them on. The folic acid, the zinc of it is on health insurance. Recently, I think last year, hydroxyurea was put under health insurance. But we all know the issues and the challenges we have with health insurance, where sometimes they go to the pharmacies and they don't get the medication. But it's under health insurance. So if you feel health insurance is free, then that is that. But the issue is it's not all the medications. They also have to do routine labs. Yes, and those ones are just the full blood counts. It's not any complicated labs that they have to do. Again, those ones, depending on the health facility that they visit, it's covered by health insurance. Just the normal CBCs, the FBCs, those are covered by health insurance. But sometimes, depending on how the child is managed, sometimes they may actually have to do other labs which are not covered by health insurance. But then for just the the clinical management, just the basic things, those are covered by health insurance. As to whether the child has to take medication for the rest of his life, we are trying to get the kids past the 5 age mark, because that is the very crucial age where they are very at risk of mortality. So once we get past them, they still take the medication till they grow, basically. It's a lifelong illness. Sickle cell disease, as it stands, has no cure. It has no, we just treat it, we manage the symptoms. So that is how it is.
We are paying more attention to the newborn screening for sickle cell because, as we well know, sickle cell it has a very huge disease burden. Disease burden meaning there's a high rate of morbidity and mortality associated with the condition. And we've realized that as part of managing this, early detection, that's via screening, has come a long way to help. Because if the enemy you are fighting is better. So screening, identifying the said condition helps a lot. We realize that in our communities too, people are faced with the challenges of understanding or even getting access to this said screening. That's why we've taken this initiative to facilitate the screening by sensitizing the people in our community about the condition. Previously, mortality rates under 1 was as high as 15%. So with children who have sickle cell, very high, and not to mention the morbidity, which is the sickness they experience, as in the complications that brings them to the hospital. It carries a lot of toll on the baby, a lot of toll on the mother and family members, affects the quality of life of the baby too. Children are brought in from school sessions are cut short because the children are getting crisis and all, and most of the time before even the mothers know this child has sickle cell, it's usually too late. So it's very important we had this initiative done so that mothers would quickly take the initiative of screening the babies as soon as possible, and if there's a need for intervention, we intervene. So mothers can screen themselves. We have the facility available for mothers to screen themselves, but the condition is a hereditary condition, so there are instances where you don't have the fathers also available for the said screening, and there are so many other subtypes. So aside the screening being done for the mothers, there is a significant need, or if I should put it, a very good opportunity to also identify the babies who are our focus to also screen them. So yes, mothers are screened, but our attention here to the babies who are born, because it is inherited and it will take genetic material from both mother and father. So yes, mothers are screened. Our attention particularly is to the babies as we speak. Knowledge is power. First of all, by screening and identifying that yes, I have this child who has a condition, is the first thing, because then quickly once these children are identified, they are put into a category, a group where they are being looked after closely. We have a sickle cell clinic at Kolobu Teaching Hospital, which is very close to our facility. These children are assessed, and depending on the severity of their conditions, management modalities are set out for them. managing their complications when they come and even preventing them. We have this hydroxyurea therapy that is giving us a lot of good results. There is even the advent of the bone marrow transplant services that is also being done. So there are so many management modalities available, but the most important thing as we speak right now is to identify the condition and then to educate, because then again, if you have a child who has a condition, you should know what will trigger whichever crisis this child will get. So that's where we are hitting hard on the primary prevention bit. Yes. So there is a process underway to actually make all of these free. But to the best of my knowledge, hydroxyurea therapy, as we speak right now, is on the health insurance. It is free. There are some advanced therapies that may not be free, but these are all very huge steps stakeholders are taking to actually make sure these services are made readily available for the children in question.
For those who already have the kits, if you haven't tested, unfortunately, because they are not newborns, it was not going to be free. They have to go to the labs to get the electrophoresis done. But I advise you that you get that done. And then for those who know that their children have the disease, please find the nearest hospital and get them there. If they cannot be managed at that particular hospital, they can be transferred to a hospital that has the resources, that has the trained pediatricians to take care of them. Sickle cell disease is not a death sentence. It can be managed, but don't manage it in your homes. Go and see the trained health people to take care of you. For the general public, those who are now coming in, those who are yet to give birth, know your status, know your sickle cell status. That is what I can tell you. Know your sickle cell status, whether you are AS, whether you are AA, whether you are S, whichever phenotype you are, know it, and then know your partner's own too. We can't make the decision for you that you should get married or not. If you have the traits or you are a career, it's up to you. All we can tell you is that sickle cell disease is a lifelong illness. It's a lifelong disease that you're going to have for the rest of your life. So just know that and make your choice. We can't decide that for you. For the other, those who are yet to give birth, we advise you that newborn screening is not done everywhere. But for those who deliver in the facilities that newborn screening is done, please let them screen your babies. And then when they are picked up as positive and then you are asked to come and see the doctors, please do and follow their advice.